just request Dr. Sangeet Mittal, who has a parallel IC to go to please share his experience on optic disc anomalies, how to go ahead. Dr. Sangeet Mittal, please.
Thank you, Saurav, for the nice introduction. Dr. Sangeet Mittal. So my topic is optic disc anomalies. How do I proceed? So there are many things you will see on the optic disc. I think the first thing that a retina surgeon or any ophthalmologist, when he examines the fundus, is look at the optic disc. And so there might be something, there might be many things which may be present on the optic disc itself. So there are various congenital optic nerve anomalies which are with systemic associations or without systemic associations. We'll come to them one by one. So we can broadly divide them into various types. The first type I'm going to describe is the metaplasias of the optic nerve head. And of this, the optic nerve hypoplasia is sometimes you see it's a unilateral or bilateral condition. The vision may vary from 6/6 to a very poor vision. There'll be a small disc. You can assess that small disc by assessing the distance between the disc and the macula, which is normally around 2 disc diameters. This will be more than 2 disc diameters. Or you can also make out the size of the optic disc, comparing it with the size of the blood vessels. So vessels are are usually of normal caliber in this, but they are usually tortuous. And it is also known as septo-optic dysplasia or de Morsier syndrome, and associated with absence of septum pellucidum and corpus callosum. So in this pictures you see, this was a young lady who came for fundus examination. She had a good vision, 6/6 in both the eyes, and you can see the size of the disc is very small. When you compare the distance between the disc and the fovea, it's around 7 to 8 disc diameters, comparing it with the normal 2 disc diameters what it should be. So this is what is the optic disc hypoplasia. Then sometimes you may come across a condition which we call optic nerve aplasia. That is the complete absence of optic nerve and retinal nerve fiber layers, and only few retinal vessels are seen. This is a very rare condition because most of the children don't survive. There are so many associated conditions with this that the children don't survive long, and this is a typical condition. You see there is no optic disc. You hardly make out any blood vessels also coming into the optic disc head. This is a condition called optic nerve dysplasia, in which the disc and the surrounding retinal tissue is totally disorganized. Then coming to the excavatory anomalies of the optic disc. So these are we are more familiar with, and we are able to manage the complications which are associated with these excavatory optic anomalies. The first one that comes is the optic pit, which is an excavation at the optic nerve head. It is present in 1 in 1,000 eyes, both males and females. They are equally seen. It could be bilateral in 10 to 15% of cases, and is a result of incomplete closure of the superior end of embryonic fissure. And this is first among the spectrum of cavitary optic disc anomalies. And it is most commonly it is located temporally, that is more than 70%, and this is the temporal location is again associated more with the maculopathy. But you can find the optic disc pit as you see in the other picture on the on the right hand side. The optic disc pit, instead of being central temporal, is central. But the closer the pit is to the margin of the optic nerve head, more are the chances of maculopathy. So Cronenberg syndrome is the association of pit with the central serous detachment, and 40 to 50% of these patients with optic pit ultimately develop optic disc maculopathy. It may be inner layer, outer layer, or both cases of the retinal layers. So I'll skip the treatment part. So coming to the next excavatory anomalies that we commonly see is the optic disc colobomas. Again, it is unilateral, most commonly unilateral. It could be rarely bilateral. Again, it's a sporadic. It is mostly associated with decreased visual acuity, and it may be associated with other colobomas like iris coloboma or choroidal colobomas. It may be associated with CNS malformations or chromosomal anomalies, or a syndrome which we call CHARGE, that is coloboma heart defects, corneal atresia, retarded development, and genital and ear anomalies, and other syndromes like Meckel-Gruber or golden heart syndromes. So this is an optic disc coloboma, which is a large disc with inferior excavation. And you see this optic disc coloboma can also be associated with the maculopathy. This was a 56-year-old female. Best corrected vision was 6/60, and there was a neurosensory detachment associated with this optic disc maculopathy. So in this case, we advised surgery, but the patient refused the surgery at first instance, but came out with a full-fledged retinal detachment a few days later, and then she agreed to undergo a surgery in this eye. And in this, we have to be careful in these conditions that the PVD induction has to be very slow, and the vitreous is very adherent to the optic disc margins and the coloboma margins, and it may lead to multiple breaks. And you see there is a communication between the vitreous cavity and the subretinal space. So this is just, I wanted to show that there is a communication. You treat this with making a ILM flap, stuffing the ILM flap, and then putting a gas inside, and this is post-operative. So another common, not common, but condition that you may come across is the morning glory syndrome, which again is a large disc with funnel-shaped excavation, spoke-like vessels emerging from the disc. There is an annulus of chorioretinal pigmentary disturbances around the disc, and there is a central tuft of white fibers, which is called glial tissue overlaying the disc. This morning glory can also have variants. This is the morning glory with normal disc size. This is a morning glory with maculopathy. Again, all these excavatory anomalies can present with maculopathies. This was a very interesting case which showed contractions of the optic nerve head. So you see the morning glory disc presented in a contracted phase, the mid phase, and the expanded phase. And what happens is when you shine the light in the eye, the morning glory disc sometimes starts showing contraction, pulsatory movements, and we were lucky enough to capture these movements in this picture. And this is the FFA we did in this patient, and you see the distance of the vessels which increases with these movements. But this is really not that rare. You have to see this. The morning glory appearance is very striking. You just see it, you label it, and you forget it. But you keep on looking at it, you may find some changes. Like in this patient, again, a 9-year-old female, you see the disc expanding, and another patient, 2-year-old female, again, the disc was expanding. So this is a patient with morning glory with maculopathy, which underwent surgery. And this is post-operative 6 months. So these excavatory anomalies presenting with maculopathy can be treated easily. Then there is a condition called Aicardi syndrome, in which this is an X-linked dominant, and there are lacunae, chorioretinal lacunae present in and around the optic nerve head. So this is a very rare condition. Patients usually don't survive the first year of life. Again, you can have a megalopapilla or the large disc without any coloboma, or you can have a posterior staphyloma, which you have to differentiate from the morning glory syndrome. In this, the whole disc is drawn inside the staphyloma. Especially if it is a type 3 staphyloma, you have to differentiate it from the morning glory disc. Some miscellaneous conditions include the tilted disc, which is again, it is common especially in myopes. And this is a small disc, oval or D-shaped, and it could be both horizontal or vertical. The tilt could be both horizontal or vertical, and it is associated with a halo around the disc on one of the sides. These are the myelinated nerve fibers which can be seen along the optic nerve head. These are feathery. They have white colored feathery margins, and these could be small or they could be very extensive also. And these myelinated nerve fibers can be present peripherally also, not associated with the optic nerve head. Now coming to the raised lesions of the optic nerve head, this is the exposed drusions on the optic nerve head, and you can see those drusions present coming out of the optic nerve head, and these may be buried also, then it is very difficult to differentiate, but exposed drusions you can easily make out these yellow lesions coming out of the optic nerve head. So this is a Bergmeister papilla, or the persistent hyperplastic primary vitreous, which has remained. It has not gone away, and you can see it is just pH, what you can call a pH PV over the disc, and it could be extensive also, like in this case. Then coming to the optic disc hematomas, this is a patient with optic disc astrocytoma. You'll see a sugary lump, not only over the optic disc, but any part of the retina it could be found. Or this is a patient with a angioma over the disc. This is a retinal capillary angioma present over the disc. And this patient, you see there's an immediate filling and early emptying while doing the FFA. This patient was treated with photodynamic therapy and showed a very good result 3 months after photodynamic therapy. These are the racemose hemangiomas, or what we call the worms inside the eye. You can see like serpents. The vessels are dilated and arising from the optic nerve head. And the difference is that in the angiomas, you will have a tumor before the two. This is a direct communication between the two vessels, which are the arteries and the veins. So we can have optic nerve melanocytomas, which are pigmented lesions lying over the disc. Again, they could be very small to very large in size. This is another patient. They had this pigmented lesion around the optic nerve head. This is again a rare condition which is associated. Usually you see these CHRPs in the periphery, but you sometimes can see in the peripapillary region also. So thank you. These are the various optic disc conditions you should be able to differentiate amongst.
Thank you so much, Dr. Sangeet, for extensively covering the optic disc anomaly.